Hey everyone! I am so excited to be here live with my good friend Alison Crouch. Yay! It's so nice being in Canada and getting to see my friends. But one of the special things about Alison is she's more than a great friend. She's also a brilliant movement coach. She was at my very first movement training and she was already a pro Pilates teacher then. And fortunately for us, but very unfortunately for Alison, she got diagnosed with severe osteoporosis a couple of years ago. So her integration of her movement background with her diagnosis has led her to really focus her current teaching on how to work with bone density issues. So I'm really excited because bone density is actually really a good idea to think about as early as you possibly can. And so we are so excited to be able to present this. Okay, thanks for jumping in. We're going to put this on our feed and we're going to put this on my YouTube and maybe Alison's YouTube also, so you can check this again. We've got a lot of great questions from you that we've organized and kind of put together. So we're going to be talking about osteoporosis in many ways today. But just before we jump in, I just wanted to say that we got a lot of questions about nutrition, supplements, and medication that we are not going to cover today because we are movement coaches and not nutritionists. So we will put a nutrition resource for you in the comments on this post and also in the YouTube caption. And Alison has a resource on how to talk to your doctor about your osteoporosis diagnosis, including medications. So we're going to post a link to that in my stories today and also on the YouTube. So we've got some stuff for you, but we're not going to cover it today. However, we will talk about a lot of good stuff. So we're going to talk about what you need to know about osteoporosis in various stages of life. So early life, menopause, and then after you get a diagnosis, or assuming you do get a diagnosis, what you need to know. So we're going to go over that. We're going to go over the best exercises for maintaining bone density. And those actually apply to everyone. So no matter what your age, you might need to lifespan modify them, but the exercises you need. And then we have a whole bunch of good questions that we'll kind of cover along the way. Okay, so I thought we would start just by asking Alison to kind of define what we're talking about here. So osteoporosis, osteopenia, we also get osteoarthritis. What's up with that?
So, such a great question. It's a really good starting point because they're different. Osteoporosis and osteopenia are conditions of bone loss. They do not generally cause pain. Osteoporosis is referred to as a silent condition because you often don't know you have it until either you have a DEXA or you end up with a fracture. Fractures obviously tend to be painful, but osteoarthritis is a separate condition. They often coexist, and I often get people saying, oh, like, I have osteoporosis and my knees hurt or my hip hurts. And so we dig a little deeper because these are not typically a place where we see osteoporosis. And it turns out that what they really have is osteoarthritis. So frequently correlated, like they can happen in the same body, but they're not the same thing. So osteoarthritis is a different condition
that we're not covering
today. Osteoporosis and osteopenia are different gradations of the same thing, which is loss of bone density. So kind of the neutral zone, the zero, I don't have osteoporosis, is basically correlated with the bone density of a 30-year-old, which is kind of where you get your peak bone mass because they needed an objective marker. Osteopenia is if you have your DEXA and it measures your bone density.
So a DEXA is a bone scanner.
To be clear. As being down to a certain point, then you're considered to have osteopenia, which is you have some bone loss, but not osteoporosis. So that would be a T-score, which is the measurement of bone density, down to minus 2.5. So I think it's between -1 and minus 2.5. If you have a T-score below minus 2.5, then that tips you into the osteoporosis category. And then that category can continue. I had a really hard time when I had my diagnosis. I was like, well, how low can you go? And I couldn't find anything. So there isn't really a low end. But I have rarely seen people go more than like -5.
It's a bit like your glasses.
Yeah, basically. Yeah.
Yeah. Okay. And then just one other point is that you're going to tend to find osteoporosis in specific body parts, and that's important. It's not normal in your knee. Where are you going to typically care about osteoporosis?
So osteoporosis is a systemic thing. So bone loss is typically going to be happening throughout. But the way they measure it is a DEXA, so your bone scan, will happen in your lumbar spine, lower back. So lower back. They don't scan your upper spine because your sternum is in the way, your ribs are in the way, and they can't get a good sense of what the bone density is of the upper back. But your whole spine is one of the places where we're most vulnerable to fractures. They will measure your total hip, which is where your leg bone meets your hip socket. And then they measure, we were going to talk about this later, but we can do it now. Something called your femoral neck, which is a narrow span bridge of bone between the big ball of your hip joint where it meets your hip socket and the rest of your femur. So if your doctor says you have osteoporosis in your femoral neck, it's not this. It's this. It's this part of your leg. Can't remember what the
Wrists.
was. Oh,
Wrists or another site.
Okay, so wrists are a higher risk fracture site. And for anybody who has severe osteoarthritis in their spine, anybody who's had a back surgery or rods because they have a major scoliosis, they will typically do a DEXA on your forearm to stand in for your spine.
And just check, you meant osteoarthritis in the spine or osteoporosis in the spine?
Osteoarthritis, because the osteoarthritis creates an artificial sense of density.
Oh.
And it messes with the measurement.
Okay, there you go. I did not know. So bone density, it's a big deal, and that is because when you have lower bone density, you are at risk of fractures. So it tends to limit what you can do in your life, but there's lots of movement ways to address that, and we are going to be talking about that because I think, many of our goals with moving is so we can live a really fulfilled life, and I think that's what we're here to support so much. So I think the most interesting thing about bone density is that, you develop it up until a certain point, and then you kind of stay steady for a while, and then you typically lose it. So it's a little bit like muscle mass, but you've got a specific window in which you increase bone density. So let's talk about what happens, kind of what you can do to think about bone density before the age of 21 to 30, which is when everything kind of ends at its high point.
So that's the stage where the balance of growing bone cells is higher and the rate of resorption or the absorption of old bone cells is lower. This is where we're building our peak bone mass. 90% of your peak bone mass is built by the time you're approximately 18 to 20 for women and 20 to 21 for men. And then you have like another little window of another 10%-ish up until you're about 30. So in that age, this is where we want to have a real focus on lots of movement variety that includes strength and weight. So lots of time spent on your feet, moving around, doing fun, interesting varieties of things, and some strength training. Right?
So we're obviously talking about kids right now, right? Because that's like up until 20-ish. So, the less kids are playing video games, the less they're on bikes, the less they're on scooters, and the more they're on their feet, carrying stuff, lifting stuff. If you want to have activity, but you also want to have weight-bearing activity. And we're going to talk specifics about that later on when we talk about exercise. But, it is a thing for kids below 20 to have osteoporosis. It's increasing, as I understand it, and it's going hand in hand with kids being less active. So for kids as well, it is actually a big deal to be thinking about bone density, both in the present, but for their future 100%. So I get it. It's not necessarily easy to get your kids out being active, but to the extent that you can, that's a great thing to do.
Good motivation. To be clear, juvenile osteoporosis is typically associated with a condition, medical condition. So it's not like you need to be out there lecturing your children about osteoporosis and your grandchildren. But this is our time, right? So my daughter is 28.
Yeah.
And since my diagnosis, she has added a whole bunch of bigger strength training activities. So, but that's not just lifting weights. She's pole dancing. Because now she's building this huge amount of upper body and lower body strength in something she loves to do.
So it's always about that match, right? You gotta like it. Yeah. So just to make everybody understand more clearly, like what is a risk factor for osteoporosis? Like what should you, so I think everybody loses bone density to some degree, the same way as we lose muscle mass as we get older.
Yeah.
But there's some people who are more likely to develop osteoporosis. And what should you be thinking about and be aware of?
So I'm actually going to use a list because I want to make sure I don't miss anything. But the basics, so anybody, once we hit that 30 peak, everybody tends to, barring some kind of medical condition, sort of plateau until we're about 50. And then most people are going to start a gradual decline. Those of us with osteoporosis, for whatever reason, it's a steeper, more rapid decline. The risk factors that you might want to be looking at include parental hip fracture. So one or both of your parents having experienced a hip fracture in their, and they've updated this to say, I believe, before the age of 80. So we're looking at a slightly younger parental problem. Greater than 3 months of a glucocorticoid steroid use. That. If you have had what is called a low trauma fracture, and chances are if you have a low trauma fracture, you're going to get assessed. So low trauma would be falling from the ground, falling from something that's less than a step, where we would typically assume that somebody would just, have some bruises and walk it off. Could be an indication. Interestingly, high alcohol intake is considered to be more than 3 drinks a day can have an effect on your bones. Smoking has an effect on your bones. Rheumatoid arthritis, which is a separate thing from osteoarthritis, right? So rheumatoid arthritis is an autoimmune condition, and there are other medical conditions. Lupus is one of them, like the autoimmune conditions often coexist with osteoporosis.
So this is, risk factors, absolutely. Yeah.
And then, I don't know if this is where we wanted to do this, but I got my first DEXA when I was in my 30s because my mom was diagnosed with really severe bone loss at the age of 55 or 56. So my doctor was like, hey, let's get a baseline and make sure we know where you're at now. But in Ontario, the general age is 65.
So in short, if you think you're at risk, if you fall into one of these categories, maybe you're a heavy smoker and you're like, oh, I'd like to check on my bones. You might make an argument with your doctor that you can get a DEXA to check on to your bone condition. Maybe the steroid use or an autoimmune condition might fly better with your doctor than smoking. So,
but there's things like my parent was just diagnosed. I'd like to, or a sister, right? Was just diagnosed.
Yeah.
Other interesting ones, low body weight. So less than 132 pounds or 60 kilograms as a general non-pregnant body weight is just an indicator.
it's a risk.
It's a risk factor. Weight loss since age 25 of greater than 10%, because that's really changing the amount of load that your bones are experiencing. And then there are certain medical conditions and medications that are used for those conditions that can also contribute to bone loss. So if you've been diagnosed with a serious thing and you're going to be taking serious medication, it's always worth saying to your doctor, hey, is any of this going to affect my bone density? I'd like to have a bone scan.
Awesome. And let me just jump in because we had a couple questions. So we're not talking about medication today, and we will put a resource for you on how to talk to your doctor about medication in the notes. And we're talking about osteoporosis, not arthritis. Okay, so I'm just going to speak to bone density today. We can talk about arthritis another day. Okay, so then you want to be active, you want to be moving, you want to be aware of your risk factors. And I'm sure there's nutritional stuff that, again, you're not going to speak to. What is starting to change as you hit midlife? So there's a big impact here with menopause, with hormonal changes for your bones.
So estrogen is a big contributor to the development of bone cells, and clearly as we hit midlife, we start to have shifts in our the amount of estrogen we have. So this is one of the reasons why we often see a precipitous decline in bone density in the first 5 to 7 years post-menopause. So if you have a big drop, maybe don't panic, because if you have another bone scan a couple of years later, you may well have plateaued, right? So that's the thing. We know that that shift in midlife affects our capacity to build new muscle mass, as well as our capacity to build bone cells, but it doesn't mean it's going to stop. right? It just means we need to work a little bit harder. So if you haven't been exercising, and now you're absorbing all of this information on the internet about like menopause is a great time to start lifting weight and really working on strength training. Same deal for osteoporosis. The best time to start is now. Today. Well, the best time to start was yesterday, but yesterday is done and gone. So the best time to start is today. And then you scale it to where you are. And you know that menopause is going to shift some things. You might be more tired. You might be having other perimenopausal or menopausal symptoms that make the idea of exercising really hard, right? You might not be sleeping well. You might be irritable. You might be anxious. You might find that the rate at which you're building strength and muscle mass is kind of frustratingly slow. But you know what? Just stick at it. Really and truly keep going, because those are the things that make a huge amount of difference in terms of your bone density going forward.
So we're going to talk again about the specifics for the exercise to think about in a minute. But the takeaway is that it was important to exercise before you were 30 for bone density purposes. It's a great window between 30 and 45 because you've got more hormones to build that muscle mass to keep the bone strong. And if you're hitting menopause right now, you still have a great window to keep working out and doing that movement. So the movement just never stops being important.
Yeah.
You may want to scale it depending on your age and stage and needs. In fact, you do want to scale it.
You absolutely do. Yes.
Yeah, there's no may about it. So specifically then, you know, as I would want to say also, it's really nice that, you know, the strength work that you can do to give yourself more muscle mass in menopause also happens to be great for your bone density. So that's a double win. So that's one of the few really good news stories that we get with this stuff. And then we just wanted to touch briefly on HRT as a, I don't know what you just pointed at. Yeah.
Are we going to do that one?
I don't think so.
Okay. Never mind.
Now I'm confused. HRT.
HRT.
Yeah, let's have HRT.
So not a doctor, not able to advise or prescribe in any way, shape, or form. But if you have a family history of osteoporosis and your doctor suggests HRT, I would seriously listen to them. This is not what I did. I hit menopause early at 44, so my estrogen really dropped fairly early compared to most people. And we have this history of osteoporosis in the family, and my doctor was like, hey, I really think HRT would be a really great idea for you. But that was at a time when we were still I was, for a variety of reasons, not wanting to do that. And it is not a lot I regret in my life. And I regret that one. HRT is a very helpful way of maintaining the estrogen levels, which maintain your bone density for longer. And the more bone cells you have, the easier it is to make more bone cells, right? So the more bone cells you have, the more effective your exercise will be in terms of increasing bone density.
So from the point of view of bone density, then considering HRT as an option during menopause is definitely something that should be on your radar, I would say.
And
now we just got a question.
It's not appropriate for everyone.
Exactly. So somebody just went through breast cancer, not eligible for HRT. Does that mean that they are without options? Of course not, because there's so many other lifestyle options that are going to give you so many ways to work on your bone density. HRT is just a little bit of a I don't know, booster.
Yeah.
But it's not the be all.
It's not the be all and end all, but in terms of like that, what are all the things that we can consider, especially around midlife? It's a conversation worth having and seeing if it's appropriate for you.
And I saw the TRX question. We're going to cover that for you when we get to the exercises. It's a good question. So before we get there, though, we just wanted to start talking about what happens. So, you know, you've gone through menopause, you go to your doctor, you get a scan, and your doctor tells you now that you have osteopenia, so that you are having some degree of bone loss. What's important for you to know if you've received an osteopenia diagnosis?
So osteopenia is the indicator that there is bone loss happening that is greater than what we would hope for, but it's not yet osteoporosis. Weirdly, if you're going to get a diagnosis, osteopenia is the good news one to get, because again, the more bone cells you have, the easier it is to increase your density. Interestingly, so the exercise prescriptions are the same as they would be for anybody who wants to work on bone density and anybody who has osteoporosis. I think what often happens is doctors say you have osteopenia, take some calcium, go for a walk, don't worry about it. But because there are a lot of people who have osteopenia and they're not given a lot of information on how they can modify their movements, there are a surprising number of fractures in people with osteopenia who then are automatically reclassified as having osteoporosis.
Oh, I didn't know that.
Yeah, so if you have a low trauma fracture, you will, and you have osteopenia, even if your numbers, even if your T-score stays at osteopenia, you'll be automatically put into a higher risk for fracture and considered to have osteoporosis.
So the big takeaway here is if you get an osteopenia diagnosis, yay, because it's like getting, I don't know, an eye doctor. You need a like, it's a warning. It's a chance for you to course correct. That's really awesome. And it also is something to take seriously because you are at a higher risk of fractures and your doctors will tend to blow it off because it's not full-blown osteoporosis. So this is it's a red flag, maybe not a yellow flag.
Yeah.
And I just wanted to jump in on our questions here because somebody was saying, how often do you recommend getting a scan? So how do you know if you have bone loss? You only know if you have a scan. There's no way of knowing, Alison didn't know until she went to her doctor. It was like, holy crap, you suddenly are like, whoa, right? You need a scan. Yeah. And how often can you get scanned? I assume that depends on you.
That sort of depends on where you are in the world. And it depends on your doctor and your situation. So because I have quite severe bone loss and because of a variety of other things, I get a DEXA every year. I think the standard in Ontario is every 2 years. Unless you are showing no signs of bone loss, in which case it's going to be every 5 years.
You can certainly get them done privately, and there's definitely options if you think you have a reason to do so. But
and again, that goes back to that list of risk factors where if you feel like you would like to have more regular kinds of information or things are changing in your world, you would go and have a conversation with your doctor and be like, based on this list of risk factors, these two really speak to my history or my physicality and have that conversation. But yeah, somewhere between 1 and 5 years usually.
So we're at the stage we've hit menopause, we're concerned about our bone loss, we have had a fracture. There's some reason that you go to the doctor, you get your scan, you're told you have osteopenia, and you watch this so you know that you need to focus more on your movement and your bone density. Do you think that I can improve my bone density at this stage? Is there stuff that I can
absolutely help? Yeah. Oh yeah, for sure. So anecdotally, again, I don't have a study in front of me of X number of people, but certainly I know of people with osteopenia who have brought their numbers back up to not having osteopenia. People often ask about, can I reverse this condition? And I don't know that as a condition, you can necessarily reverse that tendency, but you can definitely reverse the trajectory of your numbers, right? And osteopenia is a great place to try and do that. And so really focusing on that combination of strength training and weight bearing exercise, quite targeted. And again, we'll talk when we get to the exercise section. There's specific ways to exercise that most effectively target bone growth. And some of them are a bit surprising.
Yeah, so we're
we will have surprises for you later.
The movement part is happening soon. Okay, so then osteopenia, I think we talked about it. Be careful, take it seriously. You've got a great window of opportunity, get active.
And we're going to talk about what that careful means.
Yeah.
In 2 minutes.
Exactly. So now we're going to talk about full-blown osteoporosis. So this is the point where you have been diagnosed with osteoporosis of any level. So I just got a great question about whether weightlifting can be dangerous if your bones are fragile. And of course, we're going to talk about that in a minute as well. Okay, so osteoporosis.
Yeah, sucks.
Why does it suck?
Because I think it really changes our self-image. This is one of the things I work on with clients almost immediately out of the gate. Not everybody, but many people, including myself, you get that diagnosis. And I saw somewhere along there, I saw the word fragile. And we really get this message that all of a sudden you're not your strong, confident, competent self. Now you're fragile. And I think that's something that we really need to try and counter, because we're not fragile. We may be at a higher risk of fracture. We may have a lower bone density. We may even have compression fractures, but that doesn't mean we as people are less than we used to be, right? We can still do all kinds of things. I have very, very low bone density in my lumbar spine, and I sail a boat and I scuba dive and I weight train and I do Pilates and I walk and I hike and I hang out with Petra, and there's so many things you can do regardless of your T-score.
So like anything, you know, letting a diagnosis define you is not helpful, but also let's take it seriously and let's do what we need to do to stay active and stay healthy. Yeah. So I mean, once again, like with osteopenia, if you do all the right things, can you improve your osteoporosis diagnosis?
Yes. So this is one of those, there is no single answer. And I wish I could say, if everybody followed this exercise prescription, everybody's bone density would improve. And unfortunately, I can't say that because everybody is so different, right? It sort of depends on what was the cause of your diagnosis, what was your previous medical history, what is your workout history, what kind of exercise are you doing now, what can you do now, right? If you are a person who is otherwise super strong and fit and healthy and you can work out in one way, you're going to have a different outcome than somebody who is really prone to fractures and has to be very intentional about their movement, right? So there's a big span, just so I don't say yes. But also, yes, absolutely. There are people who have done a variety of different kinds of exercise protocols who have seen an increase in their bone density.
And yes, we will be posting a recording of this both on Instagram and on YouTube. So lots of ways to access this again. And I think that what Alison has alluded to just now that's important to remember is that you are not the number of density in your hip. You are a human. And so maybe the goal after a diagnosis is less about increasing your numbers and more about figuring out how you can live vibrantly and safely, I think.
Yeah. I mean, and I'm prone to the same thing. Numbers are, I mean, they're not tactile, you can hold them, but they're measurable. And there's a lot of doctors with the best, I'm very pro doctor, but with the best will in the world, they do tend to focus on the number and they make the number quite scary. And you can have an incredibly awesome active life and never even know that you have low bone density. If you never had a bone stain, you never had a fracture. So training, I don't think of it as training to increase my bone density, although that may well be the outcome. I think of it as training for my life. And I want my clients to train for their life. So what do you want your life to include? And let's make sure that you can do that or the closest approximation to it that is safe and responsible and practical for you.
Awesome. And we are going to talk about exercise for bone density and also other things that you should think about. And one of the things that you do need to think about for both osteoporosis and osteopenia is some ways to modify and limit certain movements. So there are some specific risks. So, you know, the risk with osteoporosis is a risk of fractures. So you want to be thinking about how do you limit your risk of falling? How do you limit your risk of yanking your hip around really hard? And how do you limit full range spinal movement? So let's talk about that.
Yeah. So, excuse me. My favorite phrase when it comes to this stuff is limit, don't eliminate. We're not trying to put people into a rigid box of never moving anything.
Falls. Eliminate falls.
Eliminate falls. Because if you drive a car, which is going to be more unsafe, rotating to check your blind spot or never checking your blind spot, never checking your blind spot. So we want to make sure that when you turn to check your blind spot, that's not your end range.
So let's back up and let's talk about the movements to avoid.
So if we look at the idea that you need to move your spine in real life, what are the limitations that we're trying to play around with? I'm going to have a demo model, which is amazing because she's going to get to do the things I don't actually do. So I'm just going to tip this up a little bit.
It's like things to limit a little bit.
Okay, so the first thing that we want to talk about is spinal flexion, which is the forward rounding of your spine. So if you could just come all the way down, that would be great. Let your head go. So this is full spinal flexion. So what about that would we want to limit? When it comes to flexion, we want to limit sustained, so staying in one place. So that would be like coming down and hanging out there for a good long while, right? It feels delicious, but what it's doing, can I poke you a little bit, Deborah? It's putting a lot of pressure on the fronts of the spinal vertebrae, all through the front side of the spine, and this is where we're most vulnerable to fracture. And we need to come on back up. We are looking to avoid end range forward flexion. So that might be, if you come on down to the floor, sit. Wait, sorry, lie down. And then if you roll your knees back as far as you can go, this is weighted end range flexion. She can't really go any farther than this. And she has the weight of her legs traveling back behind her. Come on down. Now roll up. So this is now weighted the other way. End range, and also weighted with her own body weight.
And let me just jump in to say, this is something you're going to see in an awful lot of yoga classes. So if you have a lower bone density, that's a thing to put a circle around, because this, I'm going to bet, is also not necessarily super ideal, right?
So that one, if you can go back into that position, yeah. We just hop forward for a second. This is what we call a compound movement, which we also want to avoid. This is flexion, side bending, and rotation all at the same time, which again is putting quite a lot of pressure onto the vertebrae on the right.
And to be clear also, this isn't stuff, if you've got a healthy spine, then by all means, these are fine positions.
Yes.
This is only for lower bone density.
So when the movements we're trying to limit are sustained, end range, weighted, and then also rapid and forceful. So that would be like doing fast crunches when it comes to flexion.
Yep.
So the next motion we want to limit is rotation. Now, as demonstrated in the car, we want to be able to twist. We want to be able to rotate, but we don't want to do it for a long time, sustained. We don't want to go to end range. So where we would see this in a yoga class would be that seated, knee up, one leg forward. This one. And then you twist, and then you're using the pressure of your arm into your leg to go past your end range, as opposed to more of a car's version or a functional range motion, where you can say, this is my range, and here's my end range, I'm gonna back it up a little bit, right, to maybe 70%, 60%, depends on who you are, right, depends on your fracture history, but keeping some motion that is not fast, it's not rapid, it's not end range, it's not weighted.
So just to go into the end range again, if I go like this, I'm pushing my spine with my elbow. I can't even get that far on my own without my elbow. So this is not quite end range for me. And then I can come out a little bit more, and that's definitely not end range. So where you are on a bone density spectrum can affect how far you go into the twist. So it's not no twist, it's find your twist.
Exactly. And then side bending, same thing. We're looking at, yes, we want to maintain the capacity to side bend, but this isn't all the way side bend. And if you take that bottom hand out of the way, so now you're not supported at all until you fall over, which we'll talk about in a second. So same thing, side bending, but more of a, instead of creating a deliberate side bend, reach your arm up. It will create some lateral flexion. So you're opening up your ribs and your spine on this side. This is a more contained version. Or you take away the weighted part. I really like to do a side bend with one hand on the wall, because that's going to stop you from going really far, and it takes some of the load off the vertebrae. In terms of flexion, we're looking at about 30 degrees approximately, is kind of the, like, for most people, it's a little bit less than that. Yeah.
Is a safe place.
Yeah.
Also,
again, for most people,
for most people.
right? These are all general guidelines.
So this is one of the reasons that if you have a diagnosis, it's often helpful to do some work with a movement teacher to help you figure out what that means for your body. Because as we're learning to move our bodies differently, we often go to places we don't realize we're going to. And that's just natural with all of that.
Yeah. So then there's the compound motions.
Yeah.
So that would be things like so in an exercise context, what Petra just showed, in a real life context, golfing gives you that kind of flexion, rotation, side bending all at the same time. Picking up,
In general?
no. I mean, if you're throwing really heavy, really hard, really fast.
All right.
But for most people, the primary part of the throw is the shoulder, understanding a little bit of rotation. But
That's
why?
golfing. Yeah, it's throwing. Pickleball.
My mother plays pickleball.
There you go.
But things like picking up heavy stuff and then turning to put the heavy pot in the oven so that you are rotating, flexing, and maybe side bending all at the same time. Right? That's a compound motion. Right. And then hips, that would be a closed chain. So closed chain is if your feet are planted on the floor and then you do a fast rotation like golf. So if you're a golfer, doesn't mean you stop golfing, but it does mean get together with a coach and kind of, you might have to pull back on your swing a little bit, but making sure that you really do let that trailing leg move so that if you look at my hip and my femur, my thigh bone, by the time I'm here, they're pretty much pointing in the same direction as opposed to a big turn where you're yanking.
No yanking. No yanking your hips. Yeah. Awesome. Okay. Any others that we need to limit or be careful of? I think those are the main ones.
That's it.
Okay.
Oh, and just as a side note, when we talk about flexion and bending, what we're trying to limit is the spine bending. We love the hip bending, right? I sometimes get people saying that I shouldn't bend. I've been told I shouldn't bend. We really want to work on this.
Okay, so I've got a question from somebody who's got mild osteopenia and who's very active and who does all the movements we just talked about. So of course you're right at that edge of like, how careful do I need to be? We're going to talk about rebounding when we talk about what exercises to think about doing.
Yeah.
So we will address rebounding. Yes, we're going to put a replay onto our YouTube and onto my Instagram, and maybe Alison's Instagram too, which I recommend following because she's awesome. So, that's why we're talking about limit, not avoid, right? We don't want you to have no movement in your life. So you can speak to that more than I can.
Yeah, I mean, I think the thing we haven't talked about yet is balance. So in terms of,
it's because we haven't talked about exercises yet.
I know, we're gonna get there, but in terms of the osteopenia thing, when you have very mild osteopenia, I think at that point it's less probably about limiting movements and it's more about adding balance training and strength training in an effort to bring those numbers back up because you're in such a great place to be able to have that, be able to have that effect. That makes sense. And then if you have a life where you do a lot of those movements really often and really intensely, then you maybe want to identify where those are and probably back them up a little bit, right? So if you have a really pronounced yoga practice and you're doing a lot of those motions, stepping them back a little bit, because I think of it as buckets, right? I have a bucket of flexion, I have a bucket of rotation, I have a bucket of side bending because I have a life and I need to be able to do those things. But I don't want to overfill the buckets. Does that make sense?
Yeah. So I hope that's clear. Yes, there will absolutely be a replay. It's going to be on my YouTube and it's going to be on my Instagram. So of course,
We'll just say that.
we would never not have a replay. All right, so I think that's the main stuff we have to say about kind of what happens in your ages and stages. So that means we get to go to the fun stuff, which is how can you maintain your bone density. And I want to just reiterate that this is the same basic stuff if you're 20 or if you're 45 or if you're 75, but you're going to scale it to your capacity at that age.
Yeah, for sure.
So how do you maintain bone density, Alison?
Well, you maintain bone density through a combination of, and we're going to define these extremely carefully, weight-bearing exercise, impact, and resistance training.
Let's define them. What is weight-bearing exercise? Which is not lifting weights.
Which is not lifting weights. It's so weirdly worded. Weight-bearing exercise is about when you're in positions where your bones are bearing weight, where your body is bearing your own body weight and gravity. So weight-bearing exercises are things like walking, running, jogging, jumping, skipping, hopping, stair climbing, hiking, dancing. Dancing is a really good one. Anything where you're upright and gravity is pushing down on you. Right? It's that combination of the force of the ground coming up and the force of gravity and your body weight coming down, kind of squishes the bone cells a little bit and stimulates them to grow.
Which 100% does not include cycling or swimming. So those are great exercises for other reasons. They are not weight bearing. So if you're thinking bone density as a priority, you need to make sure you're getting ample other stuff.
Actually, yeah. Treadmills, yes. Ellipticals, not so much. Yeah. Right, because you're upright and you're weight bearing, but your feet are not.
So it's about the impact. It's about the impact. There's lots of value to jumping type stuff anyway. There again, you look at that other menopause piece where you're building bone, you're building power, you're getting intensity.
Yeah.
If you can have a plyometrics or a box jumping practice, I am betting that that is really great for you. And I keep saying rebounding, so let's just answer the rebounding question.
Let's do it.
We feel a little about rebounding.
We do. There are some studies that claim that rebounding is good for bone density. And again, because the studies throughout the osteoporosis world are pretty new, rebounding studies are very small. The big thing that you're getting with jumping is the impact. And that impact is degraded or decreased the softer the surface you're landing on. In addition to that, so rebounding, great for cardio, great for muscle strength, super fun. If you love it, keep doing it, but it's not going to be your primary bone density building activity. The other thing to be mindful of is if you have a hyperkyphosis, if you have a forward bend, and if you have a history of fractures, a couple of studies really indicated that people who didn't have great rebounding technique and were really kind of leaning onto the handles, presumably for balance, were prone to fractures.
So rebounding is basically jumping up and down on a mini trampoline. Sorry, that wasn't clear. Yeah, so the difference between jumping on a hardwood floor and jumping on a rebounder is less impact, which is why the rebounder is fun, because it gives you more spring. It is also not clear, like it is possible that it's going to give you some really good bone impacts. But I think that, you know, just logically speaking, it seems slightly less likely to give you as much as jumping would because the impact is lower.
Is less. Yes.
So again, rebounding probably awesome, but maybe not for bone density as your go-to.
Yeah. No, that is my take on that.
Okay, we'll try to talk more slowly. That is my great failing. I'm sorry.
Me too.
We're sorry.
We apologize.
So weight-bearing exercise, and we wanted to touch on shoes for weight-bearing as well. So this gets interesting and nerdy because shoes have cushion. Cushion decreases impact, maybe, because some studies have shown that when we wear cushion shoes, we actually step harder onto the ground. So our bodies are very interesting, and we don't have full studies on all of this stuff to give you definitive answers. So my heart says that walking in minimal footwear is going to give you a optimal bone building impact, the most optimal walking related bone building impact, because that's how our bodies evolved to walk. But there's no science that would agree with that, I would say.
Not yet.
Yeah.
And the proviso to that is if you are prone to foot fractures, minimal shoes, not probably the right choice for you, but an ultra would be great, or a lens, right?
Which is
where you can
transitional
have a transitional shoe that's got some cushioning, but it has zero rise and it has a wide toe box. But yeah, same, right? And again, if you have arthritis, if you have reasons why wearing barefoot minimal shoes is not comfortable for you, that may not be so much osteoporosis related, it's more arthritis or plantar fasciitis related, then of course you're going to approach the shoe choice in the way that makes the most sense for you. Even if you're like, I want every single thing that's going to stimulate my bones, don't do it if it's not going to work for you, right? And then of course you should with Petra because she knows all the things about feet and shoes.
So, shoe toys is just an interesting aside because we're talking about impact. And just really quickly, yes, men can get lower bone density for sure. It's just much less common.
It's actually becoming more common.
More common.
Not more common than women, but the incidences of men with low bone density is increasing. Part of that is because of medical conditions and medications, right? So cancer is the big one. Cancer treatment typically decreases bone density, and men are just as prone to that as women. So that's part of it. But yes, absolutely, men can end up with low bone density too.
Yeah, great question. And we should have mentioned that. Okay, so I think we've covered common weight-bearing exercises, and we're actually going to demonstrate one that we love in just a minute. So good, so fun.
It's so easy.
But we also want to talk about resistance training, aka lifting weights.
Yes. So this is where this wording is so complicated. Weight bearing
is not
something you do with weights. Strength training or resistance training is something you do with weights. The most current research is pretty consistently indicating that progressive strength training is probably our number one tool in terms of increasing bone density. Weight training is safe for people with osteoporosis, and form and technique are incredibly important because, as somebody commented, is it safe? Our bones are more fragile. I tend not to use the word fragile, but I know what you mean, right? We are more higher risk of fractures. We really want our weight training to be very well done. Progressive means that it gradually gets heavier over time. So if you are going to your fitness class, and you've been going to your fitness class or your Pilates class or your yoga with strength class, and you've been using 2 or 3 or 5 pound weights for 2 or 3 years, or 10 or 15 years, they are no longer stimulating your bone density. You need to be gradually always working towards a slightly heavier weight at a rate that makes sense for you. So some people will progress within a matter of weeks, and some people will be days, and some people will be months, right? Very individual.
And once again, the huge benefit of this is that the research seems to be really pointing to the fact that for women especially, it's hard to maintain muscle mass as we age, but very helpful to age well. And so the same stuff that will help you maintain your muscle mass, which means independence and independent living and having dinner parties when you're 85, is the exact same stuff that's going to help with your bones. So there's a real win there.
It is such a win-win.
Yeah. Okay, so we want to be thinking about weight-bearing exercise and about resistance training. And I think we both agree that one of the best things you can do for yourself with weightlifting is, what's the right word? Get some coaching and learn how to do it safely and with good technique in a way that's scaled to you. And we were talking when we were prepping for this about my experience in Java. So I've just gotten back to the gym, and I'm not a new to the gym person, but it's been a while. And, it's intimidating. You go in there's often a lot of men. It's often a lot of stuff you don't understand. You can waste a lot of time in the gym, and you don't really know what you're doing. So it's weird. So I think it's very excellent if you go and get a little bit of help. There's lots of great coaches out there, including Alison, who will show you some of the basics of bone-friendly weightlifting. But again, the technique doesn't, I think, change particularly. And there's some basics. It doesn't have to be rocket science. But get yourself some knowledge about weight lifting, resistance training. Start lightly, be careful, learn the building blocks, because there's no rush to do heavy stuff, because doing heavy stuff without the building blocks is going to leave you potentially in a worse position than before.
Yeah. There's just as a side note, there's a very well-known, it was kind of the groundbreaking study about progressive weight training and osteoporosis called the Liftmore trial, which was done in Australia. And so everybody gets very excited about the weightlifting part of it, which was the change maker. But what they don't know or haven't absorbed is that they spent 3 months in advance of the weights working with kinesiologists, physiotherapists, and trainers, working on the joint mobility and the technique, right? They were ready before they started lifting heavy weights. So if you're like, I don't want to start leaping into heavy weights, that's okay. You don't have to.
Give yourself the time.
Yeah.
A couple of specific types of weights are being asked about. So kettlebells, I would say.
So kettlebells are great. I love kettlebells. I have a multitude of kettlebells. Kettlebell swinging, probably not so much because that is fast weighted. And the theory is you're doing it with a long spine if you're just like doing straight up swings, but most people are going to end up moving their spines a fair degree. But kettlebells, like using them for deadlifts, using them for lunges, using them for carries, you love them.
But then you're not really kettlebell training. So there's nothing wrong with them as a weight, but the classic kettlebell work may be best to modify. And just to jump on here, Alison will be tagged when I post the replay. You can always DM me if you can't find Alison otherwise. Alison is easy to find.
Yeah, I'm pretty sure if you search Move Smart or you search Alison Crouch or you search osteoporosis, I'm pretty likely to come up on Instagram.
Or just DM me if you can. So we're here to help you.
We're going to help you find you.
Yeah. What about vibration platforms?
Again, there is an insufficiency of repeatable evidence.
Okay.
So there is definitely evidence that vibration plates, the good quality ones, like we're talking about the $2,000 to $3,000 versions, the $200 ones you get off Amazon, please don't use them. The research largely comes out of two places. It comes out of using vibration plates as part of an athletic endeavor. So they have been shown to increase strength, balance, they increase the challenge of a workout for sure. And then they've been used on astronauts coming back from space, because when you go into space, let me try and remember to slow down. When you go into space, there's a lack of gravity. So that would be the weight-bearing exercise part, right? People are no longer weight-bearing because they're in space, they use bone mass, they come back, and vibration plates have been part of their bone restoration. They tend to be young, fit, healthy men, and they don't have osteoporosis. So it is a little bit challenging to extrapolate that research into our population. There has been some research to suggest that they do work. And my grandmother used one up until she was like 101. And some people have had good success with them. So my thing is, if you can afford it and you want to give it a go ahead. They may
really quick, what's wrong with the $200 ones?
They don't have nearly as well engineered vibration management. So like everything else with vibration, you want to be gradually scaling the amount of vibration. Bones respond to a very specific hertz of vibration. And I'm sorry, I can't remember what it is off the top of my head, that we're kind of working within this zone to this zone. And the ones that are less expensive are less reliable, and they will go too fast or too slow. And often, again, they're meant for people who want to increase their workout, right? They're using them for different purposes.
So we're going to say, save your money, get a gym membership, do stuff that's known to work, and go from there. TRX. Is TRX resistance training?
It is body weight resistance training. It will strengthen you. It does not have the benefit of the load element that, for instance, a squat does or that a lunge does, where you're both upright and holding weight and working weight. Most TRX exercises are really working upper body muscles, which is fabulous and training for your life, but less helpful. Like if you think about, you've got your TRX and you're leaning back and you're doing a reclined row, there's no gravitational load on your bones.
Yeah. So you're thinking like pretty like classic weight training type stuff is usually what you want to be thinking about with the resistance training. So squats and lunges, deadlifts, the kind of the go-tos. You don't need to get super fancy. Yeah. Okay, I think that covered. Oh, jump rope. Yes, absolutely, jump rope. Anything jumpy is fabulous. Yeah. The squatting is great. Well, I don't know about TRX and squatting, or I don't know what you're asking.
So if you're using a TRX to facilitate a greater amount of motion, that would be a great prep. But holding on to the TRX as you squat is decreasing your load. So it's increasing your range, increasing your capacity in terms of how far you're going into the squat, but it's not adding that extra weight challenge that would happen, for instance, if you're doing a squat. Well, so if you imagine, I have, Petra, please be my assistant. So we're going to imagine this is a TRX. So hold me good, girl. Okay, don't fall over. So if I'm coming down and back this way, most of the work here is actually in my arms, hanging on to the imaginary TRX. And it really increases my range. So I'm getting all kinds of fabulous exercise, but it's fundamentally different. Sorry, don't fall over. Than having a weight which is increasing the downward force for my exercise.
Yeah.
Right?
So I think, if you haven't squatted, then the TRX is maybe going to give you a little bit more capacity and build it. And at a certain point, you're going to say goodbye to the TRX and hello barbells.
Yeah.
So dumbbell.
Right? And so, and then eventually, if it's appropriate for you, you would go to a back squat, which is a barbell across your shoulders, if that's appropriate for you, with, of course, the right amount of supervision and training. That's not where you start.
Yeah. So I think that's most of the yes, do these exercises, but I did want to just touch on one other thing, is that a lot of doctors are going to tell you that walking is the exercise you need for osteoporosis, and unfortunately that may not be true, and here's why.
So walking is great and fully endorse it as an activity. It may have some benefit to people who are quite deconditioned. So if you've been super sedentary and you've not done any exercise, walking might be enough to stimulate your bones. But your bones need to be, if you think of your bones as toddlers or kittens, right? They get very excited about things for a short amount of time and then they're done. And you need to give them something new. Bone cells are the same. Bone cells respond to greater than normal everyday amounts of stimulation. And so if you have a walking practice, or if you I live in a neighborhood where it's not even a walking practice, it's just my life involves a lot of walking. My bone cells are totally acclimated to that amount of stimulation.
They don't even care.
They don't even care. And there is a study, and I have been desperately trying to find this study so that I can link to it. And I found some other stuff. If anybody's interested, message Petra and I can send her some links to research.
No, don't do
that. Don't do that. Don't do that.
Message Alison.
Come and message me and I will get you some research links. But at some point I saw a study that says bone cells in laboratory conditions stop responding to the same mechanical stimulus after 20 to 60 cycles.
So a cycle is a step.
It's a step.
So your walk might be good for the first block.
Yeah.
And then after that, you're done. You're done. You're not getting anything. So unless you pick up a couple blocks and you got 60 more steps, then your walk is over from the point of view of your bones. But Alison has the world's best exercise that we're going to demonstrate for you that you can do as a work break, 3 times a day, 4 times a day, super easy, 20 to 60 times, and it's super bone building, and anyone can do it. So why don't you walk me through how to do a heel drop?
Okay, so a heel drop is a lift of your heels.
Whoa, you can hold the wall.
You can hold on to the wall, yeah, for sure. And then it's a real bump down of your heels.
Whoa, look at that. We better
Yay! And so this is more stimulation than walking. It's more stimulation than your bone cells are adapted to as just part of your everyday life. 20 to 60 cycles. And then it's kind of wearing off. You can do it in your kitchen. And the thing I really love about this is you can modify it to fit your needs.
So if I'm super awesome at my heel drops, I can grab Alison's weights and add a little bit of extra.
That's right. If you're at a low risk of fracture. Yeah. So one of the things that's great about this is if you are at a low risk of fracture and you are accustomed to movement and you're strong, you add weights, you really go for it. If you're at a moderate risk of fracture, you could come down a little more lightly. You could come down in shoes. you could come down, I'll do this on my back deck and I do it like over a joist. So it's really good. It's a good bump down. I'm at a moderate risk of fracture. I have very low density in my low back, but I'm also super active and super fit and I do this stuff all the time. So I'm well acclimated to it. But if you're at a high risk of fracture, then you just lift a little bit and you're still getting more. The ballpark for that is you want about the same amount of impact as you would get on a brisk walk, right? So there's one other note.
Yep.
I often hear people say, do it with your knees bent. And for any guys, anybody who's here live, you can try this right now. If you stand up with your legs straight and you lift your heels to whatever height is appropriate and drop them down, you'll probably feel the vibration coming right up through your legs to your hips. Now bend your knees and do it again, and you will feel it in your calves. Wow. And the vibrations really gets diffused every time it hits a bend in your system. So if you have arthritis in your knees and a big drop is too much vibration, doesn't feel good in your knees, rather than bending your knees, go for a smaller drop and just experiment until you find the height or the degree of softness. Right, on a carpet, on a mat, fold your mat over, wear shoes. There's really no way to lose with this one. It's so good.
So super scalable, super easy to do in your house. You only do 40 to 60 of them or so, and you can do them anytime, anywhere. So that's a great takeaway exercise, very weight bearing. 3 sets of 20 for a total of 60 would be a great way to do it, or just do 60 or whatever works for your body. It's just a bone builder. It's not so much a calf raise, although it is also.
There is also a calf raise in there. And that same study that I can't find the link for suggested that 2 hours was the optimal interval. So you're not really going to gain anything by doing a set and then 5 minutes and then a set.
Well, I think 20 minutes and 60.
2 hours is the optimal interval,
but you get 60 reps.
Yeah.
Okay. So that kind of stuff just isn't totally clear. So do you do 1 set of 60 or do you do 3 sets of 20 and then wait for 2 hours for both? We don't know. Yeah. So sorry. Just it doesn't exist. That information.
Doesn't.
Yeah. Is there any issue around osteoarthritis and doing heel drops?
If it's uncomfortable, then
it's always tough. So arthritis is really tricky with that because pain and arthritis doesn't necessarily mean you shouldn't do the thing. I would try it, see how it feels for you. You might be able to modify it down a little bit. You might be able to think about some other options, maybe walking's fine. It's not the only exercise you should do.
Yeah.
It's just an option. We have been an hour now. I've got one more thing we really want to talk about because bone density focused exercise is not the only exercise you should think about with bone density in mind. And we want to talk about that for about 10 minutes. We will repost this because I know this is going to be a long one if you need to go. And yeah, doctors aren't necessarily super informed on the movement side of things. So that's why we're doing this today. Hiking up steep mountain trails, up and down with a backpack, 100%. But use your hiking poles because
hang on just a second.
Also,
backpacks.
Yes,
Backpacks and weighted vests. They're on the list somewhere.
Yeah, we missed them.
Okay. So for some people, backpacks and weighted vests are awesome because they're adding that extra bit of load. But again, bone cells adapt really quickly. Mm-hmm. So we used to say, and in fact, I said this the last time Petra and I did a presentation about osteoporosis, yay, weighted vests, use them all the time. But we now know that, again, the bone cells acclimate. And so wearing them for a 1 hour walk or a 3 hour hike, in terms of the bone density effect, not so much. So the current recommendation is more like if you want to use a weighted vest, use it while you're doing your squats, while you're doing your lunges, while you're doing your stair climbing, for shorter bursts of time where the bone cells will be continuing to get that novelty stimulation. And if you have a history of fractures, if you have back pain, or if you have hyperkyphosis,
which you might hide like this, by the way.
You might hide like this,
yeah.
Or a forward head posture, a weighted vest and potentially a backpack are going to put more load on the fronts of your vertebrae. So,
but maybe not a weighted vest.
So weighted vests and backpacks are a bit of a like personal, good for some people, not so much for others.
But just to be clear, it's still great to go hiking, because walking, because you're still
absolutely.
getting 60 steps on a mountain. And if you're hiking up and down hills, you are changing the load, because when you go down that hill, you are getting a lot of impact, typically, depending on the terrain. So, there you get variability, and the bone cells will respond to variability. So I'm going to guess that hiking would be a really good idea.
Hiking is great, and hiking also gets into what we're going to talk about shortly, which is it's not just about the bone density exercises specifically. Hiking gives you great lateral hip strength and different angles and loads, which speaks to bone quality and bone strength and resilience relative to fracture, even if it's not addressing bone density specifically.
So yeah,
so it's fun.
Also fun.
Do the things you love.
Yeah. Lift More, I believe, did cover weightlifting. Somebody just said their doctor pointed them to Lift More. So Lift More, they got a Lift More online program that doesn't do weightlifting because they can't tell if you're using proper form. Okay, that makes tons of sense. Yeah. As far as online programs to take, I'm just gonna give Alison a big shout out here, because she has an online program where she does offer a ton of eyes on you coaching. And when it comes to movement, that's so valuable, because what you're going to find is you don't know how you're moving when you're moving. You think you're doing one thing and you're doing something else. So having expert eyes like Alison can be huge, and also someone to answer all your questions. So definitely, yes, it's all being recorded. I always have a replay. You can count on a replay. Don't worry. So we're going to finish, I think, talking about the other movements that are really important that are not specifically bone density focused. And let's start. What was number one as the thing you should think about?
This is so unsexy, you guys.
No, it's sexy. There's nothing sexier. I love it.
Balance. The number one recommendation from Osteoporosis Canada for people with osteoporosis is not actually strength training. It's balance. Because the sexy part is you can live a fantastic, active, rewarding, pain-free life. Oh, okay, pain-free might be overstating it, but pain-free from osteoporosis if you avoid falls and fractures. There are such things as compression fractures, which sort of happen spontaneously, but most fractures
spontaneously when you crunch over like that.
Yeah.
So
most fractures are the result of falls. Studies show that we all, even the people who say, I had great balance, our balance starts to diminish after about the age of 40. And so in order to maintain all the things you love to do, like my mother playing pickleball at the age of 80 with severe osteoporosis, we want to do static balance, we want to do dynamic balance, we want reactive, like how do you respond to an external pressure? Distractive balance training, so like throwing balls back and forth with somebody while you're standing on one foot,
or throwing a ball at a wall while you're on one foot, because that's also reactive.
Yeah, all this kind of stuff. This is the number one recommendation. They now say you want to do about 2 15-minute sessions a week on targeted, intentional. Make it more challenging as you go, so you feel like you're always having to work at it a little bit. Balance training.
So just as a side note on that, what supplements balance is good foot capacity, so foot mobility, foot strength, foot sensitivity, not being in those cushioned shoes, good hip strength and mobility, because again, those hips work with the feet to give you balance. And because when you have mobility, if you use your joints often, you have a better brain connection to your joints. So you want strength and mobility to give you balance, which will supplement those 15 minutes twice a week of actual balance training and be great for your feet and your hips. So again, this stuff is overwhelming when you start to dig into it, but when you start working on it, it complements it. It's very self-reflexive, I guess you could call it.
Yeah.
So the foot stuff is also osteoporosis stuff. So who even knew? Who knew? So balance is huge. Definitely work on balance in so many ways to do that. Okay, what else should you be thinking about if you would like to have a super awesome life?
So this is where Petra's and my work comes together like peanut butter and jam. Alignment is a really key portion of the program, because how your bones load when you're doing weight bearing exercise, how your bones load and your form and function work when you're doing strength training, very much about alignment.
Let's go talk about that for a second. So we met at essentially an alignment and movement course. And alignment is sort of like posture, but kind of more like getting your car's wheels aligned so everything works better. So, in terms of load bearing and weight bearing, you will notice many people stand around like this. And this was my standing, and I think it was your standing too. This is very normal. It's lazy standing because you're hanging off your ligaments a little
And
bit
it's kind of cool that we have two different versions of the same thing.
Yeah, because
Your
your
whole
whole body
body
is
is
forward.
forward.
Yeah,
And I'm in a bit of a bow.
you're a bow. So anyways, this is crappy no matter how you slice it, because what we're doing here is we're shortening and compressing our pelvic floors, and we're squishing our feet, and we're not doing great stuff for our core. We're also not bearing any weight in our hips. So learning to stand hips over heels is a key element of everything we both teach, because when you're standing hips over heels full time, it's nicer for all of your muscles and things that work. But guess what? You're also getting more weight bearing in your bones.
Yeah.
So that's one like classic example. And then when you walk, you're walking more like this and less like, I can't even do it in the way. Less falling forward. So when you walk, you can walk very vertically, or you can walk very falling forwardly.
Or you can walk with your hips really far forward.
Yeah. So there's a bunch of ways to walk, and those are all going to affect how your bones are loaded. So we think alignment is a really helpful tool to optimize your whole body loading, I think we would call it.
Yeah, it becomes like a meshing anchor point for all the things that you do when it comes to bone health.
Yeah. And then when we're talking about spinal stuff, another common one in my rib cage magic thing, we talked about this. This was me too. So I was this actually. So that was awesome for my spine. So what I'm doing with my spine here is not that rounding forward compression, but what I'm really doing here is I'm hyperextending at my lowest spine. So my spine could actually be quite rounded on top, and then I've hyperextended it by leaning backwards. So you don't even see the hyperkyphosis that I'm hiding because I've rotated here. So you can mask what's happening in your spine with your clever alignment strategies. So again, getting the alignment piece helps you nourish everything in a more comprehensive way. And then you want to go weightlifting and add a load. The alignment piece is going to really play in here, because
There's a
that's
big
really
difference
different
between
from this
and this.
and that.
This is not going to feel good. And if you add weight,
It's going to really.
it's not.
Don't do it. Don't do it.
I'm gonna do it one time. So if you're doing a deadlift and you're coming down, you're following the technique, and you've got your weight nicely in front of your shins and you're hinging your hips, but look at the curve in my back. This does not feel great. Is it an issue for osteoporosis? Not specifically, but you're not getting the most out of it as compared to that, which is not flexion, right? I'm not here, which I wouldn't want to do. But it's a tiny, and it's tiny, and it's a little bit hard to locate on your own.
It's the how. It's the technique. It's subtle, but it gives you a difference in your outcomes and your results, and that's one of the reasons that we both think it's important. The same way that you can have bad deadlifting technique, you could have bad. I sat in my kitchen and made a coffee technique. So we think that it's worth thinking about.
Yep.
All right, and so let's talk a little bit about mobility work. Again, not obvious for bone density, but there are some. Yes, it's very hard to see your own alignment for sure. It takes practice. That's why we're here.
And use your phone.
Yeah, or your mirror. Film yourself. Look at
Even more than a mirror,
the phones.
because when you're in a mirror, you'll keep looking,
Yeah,
and you'll see a little bit what you expect to see. If you film yourself doing your exercise,
you'll be horrified.
You'll be horrified. From whatever plane is going to give you the most information, right? So if you're trying to address rib thrusting, you're going to film from the side. Film yourself doing 2 or 3 of them, and then watch.
Be your own coach.
And you'll be much more objective when you're looking at a videotape version of what you're doing, and you can be your own coach if you know what you're looking for.
Yeah. Okay.
Joint mobility.
Mobility. What is the point of joint mobility when it comes to osteoporosis? All the things. So joint mobility is something that we're also both trained in, a certain approach to it. I think it's a very good approach. So joint mobility means how much can you move your joints with control and capacity.
And
so it's not
precision and awareness.
Yeah. And then working on it and maintaining it, because that underpins everything. If you do not have mobility, then if you either can't do a thing, or you're going to get a weird compensation to do a thing.
Yeah.
So mobility can be lacking if you're super flexible and don't have strength and control, or it can be lacking if you're super stiff and don't have range.
Yeah.
But either way, you're not getting the most out of your capacity. And the reason that becomes a big problem with osteoporosis is then you start to lose the ability to do the weightlifting.
Well,
And
and so, yeah, so first off, if you're gonna weight train, if you're gonna strength train, you wanna be doing that with full mobility. If you're gonna do an overhead press, I want you to be able to smoothly get your arm overhead without weight before we start adding weight. This is actually, so this will be one of the things you sometimes see in our limitations. People with osteoporosis shouldn't take their arms overhead, which I have real quibbles with, and those of you familiar with the Liftmore trial will know that the overhead press was one of the exercises that was safely done in that trial. My thing is more like, regardless of who you are, if you can't get your arm overhead, then this is not where you start, but we want to get you there. So yeah, joint mobility preparatory to strength training, but also one of the things we really want to avoid with osteoporosis is that forward curving hyperkyphosis, short and tight across the front of the chest and shoulders, because it gradually puts more and more pressure on the fronts of the vertebrae. And if you don't have range of motion, true isolated capacity for both isolation and integration movement of your shoulders, this is one of the things that happens. And this affects your balance. It makes you more likely to fall forward. It puts excessive pressure on your vertebrae. It doesn't feel good. And if you've been given a diagnosis, which is also making you feel old before your time and you're kind of being pulled forward, it's not a happy making combo. So really being able to work on finding the position of your arm in your shoulder socket, working the range of your arm in the shoulder socket, which increases your body's understanding of where your shoulder socket is in relation to the lower angiome in terms of the rest of your body, means all of your movement is going to be better and your everyday positioning is going to allow you more access to upper back strength.
Awesome.
Okay.
So, and that's upper body mobility, which, you know, you don't necessarily even think of with respect to your spine or your hips. And of course, it's the whole way up. Your knee mobility matters and your hip mobility. And so mobility underpins everything else. If you want to move well, having a sense of mobility, a focus on mobility in your practice will serve you well.
And for anybody who's got arthritis and osteoporosis, that is totally a win.
Yeah. So then we are definitely starting to run short of time, and I know you all have to go. So I just want to say really quickly then, 2 more things to really think about are breathing as part of the process, because breathing, spine, core, that's all part.
Connected.
It's all together. So, you know, if you don't want the hyperkyphosis, one of the things is you want to be breathing well, and breathing itself is a mobility exercise. And finally, hanging from the monkey bars. So I'm going to give a little preview of this fall. We're going to be doing a workshop, a free workshop on how to start hanging, how to start from zero and get yourself onto the monkey bars, even if you haven't been on there since you were 8 years old. So that's a great osteoporosis supporter. So, there's so many more things to say, but we never shut up. So we're going to finally shut up. We absolutely will be posting this on our Instagrams, on YouTube, and you can reach out to me at Petra Fisher Movement, Alison at @AlisonCrouch_MoveSmart, and she'll be tagged on this. And we are so pleased that you guys have decided to join us. And thank you. Hi to Morocco. I'm going to be in Morocco in November, so yay.
Fantastic.
And we're super, super glad you blah, 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 blah. I can't even talk anymore. Oh, all right. Thank you, everyone. Thanks for coming. Great to see you, Judy. Thank you, everyone. All right. Take care, everyone.
Bye.